Dad, when are you going to die? I slowly open my eyes and see my 6-year-old daughter staring at me with a look of concern on her face. 6 o'clock on a Monday morning. Far out, my head starts spinning. What's she going to ask next? The meaning of life? Where babies come from? Or worse, can I watch Barbie? Way too early in the week for this. I don't know where I even signed up for this anyway. But in a way, it kind of is my job. Not just as a parent who somehow is supposed to have an answer to all life's impossible questions, but because I'm a demographer and a health geographer. Oh, what the heck's a demographer, health geographer? Well, I like maps, and my job is to use data to understand more about people and place, and how the environments we live in influence our health. We don't know when we're going to die, and none of us can live forever, but some of us will live longer, healthier lives than others. In New Zealand, there are deep, persistent, unfair, and avoidable differences in health. That's the definition of inequities. And definitions are important, especially this one, because while inequities are unfair, they're also avoidable. So that means we can do something about them. The other thing about inequities is they're not very Kiwi. We like to think we're this nice, big, fair society where everyone gets a chance. But there are big differences in what we call the social determinants of health. These are the living conditions, factors like income, housing, employment, education, and access to services that are the biggest drivers of our population health. Oh well, that's life, you might think. But these big differences affect us all. And health inequities mean that people in New Zealand are dying before their time. So what does that mean for me and my daughter's question? When am I going to die? The average European male can expect to live to 81. For Māori men, that's 73, and that gap's grown since 2014. And for people who live in the poorest areas of New Zealand, average life expectancy is 9 years shorter than those who live in the wealthiest areas. The environments we live in matter. A report from the National Health Committee states that the link between poverty and ill health is clear. The financially worst off in society have the highest rates of sickness and early death. Housing costs have increased dramatically in the past decade, and socioeconomic status is strongly associated with ethnicity. The scary thing is, that's an old report from 1998, and the story hasn't changed. Well, I guess it kind of has a little bit. We've recently discovered new disparities. If you live in a remote area, you're up to 3 times more likely to die before the age of 30 than if you live in a city. That's crazy. What's even crazier, though, is that until 2023, we didn't even know this fact. How can that be? Has something suddenly changed about life in rural New Zealand? Are the sheep and cows turning violent? Spate of ram raids, maybe. The real answer is much more exciting, of course, if you're a nerd like me, because it comes back to data about people and place. The truth is, the health outcomes haven't actually changed, but how we look at that data makes a huge difference. And what we define as rural and what we call urban matters. Okay, so what is rural in New Zealand anyway? Well, previously, generic classifications used things like urban form. That's what places look like on the ground, whether you've got clusters of houses or rolling green meadows, and considered population density and size to define places as rural or urban. And that makes sense in most generic situations. The problem was when health researchers took this definition and used it on their data sets, it meant that small towns like Taumaranui were grouped together with big cities like Auckland in the urban category. and that made a lot less sense. And it produced strange results which just didn't reflect the reality that rural communities and their health practitioners were experiencing. So, under the leadership of Professor Gary Nixon, we set out to create a new, fit-for-purpose geographic classification for health. We actually used a lot of the same building blocks, population density, size, and travel time to urban areas, but we set thresholds that made sense for health. And we talked extensively with stakeholders to validate the classification and make sure that it made sense on the ground. Okay, cool story, bro. Why are you telling us all this? Well, where previous generic classifications had towns like Matamata, Tiro, Patararu in the urban category, our fit-for-purpose geographic classification for health more appropriately classified them as rural. And the small change actually made a big difference. When we looked at the same big health data set using these different classifications, we found that generic ones systematically underestimated rural health outcomes. When we looked at potentially preventable deaths, using a generic definition, these were slightly lower in rural compared to urban areas. Using the geographic classification for health, potentially preventable deaths were 20% higher in rural compared to urban areas. We had the exact same data set, but using a more appropriate classification gave you a totally different conclusion. Generic definitions were masking disparities. But what's behind these disparities? Well, a large part of it comes back to the social determinants that I mentioned earlier. We might imagine a rural utopia where people live healthy lifestyles in the great outdoors, in touch with a pristine natural environment. But the reality can be quite different with harsh living conditions. Census data tells us that rural populations tend to be older and poorer. They're more likely to have lower income, fewer qualifications, and worse access to internet and cell phone connectivity. Wealth tends to concentrate in our cities, and rural residents are more likely to live in areas of high socioeconomic deprivation. This is worse for Māori, especially in remote communities where 73% live in areas of the highest deprivation. On top of all this, poor access to services can contribute to health disparities. Advocacy groups have highlighted this for a long time. It's even in the government's own rural health strategy. They've got an aspiration of more services closer to home. But how do you actually make that happen? We can't really put a brain surgeon in every single town, and every time I open the newspaper, there's a new health crisis. Massive waiting times, workforce shortages. How do we do things differently, make things better in a crisis? Well, maybe we can look to a crisis from the past and see what we learned. Has anyone heard of COVID-19? Yeah, it was tough, right? We had lockdowns, travel bubbles, travel bans. We had to figure out a whole new way of basically doing everything. We also had to figure out, how do you deliver a vaccine to the whole country as quickly as possible? Sounds easy enough, man. We've only got 5 million people. The challenge, of course, is how do you do it fairly? How do you make sure that everyone who wants to has the chance to get vaccinated? How do you avoid another postcode lottery? In June 2021, I made some maps, and my colleagues and I wrote a paper highlighting the impact of different vaccination rollout scenarios. We found that a strategy of mega clinics in hospitals or stadiums, or even just using the existing health infrastructure, would lead to disparities. Priority populations who were at the biggest risk of a severe impact from COVID-19 would actually have to travel further to access services. So in this context, we suggested a geographic targeted strategy, making sure that priority populations had good access by springboarding effective outreach from GP clinics, Māori providers, and Pacific Health Services. Fast forward to October, and the rollout was well underway. The government had a target of 90% uptake, and 65% of people had already had 2 doses. But gaps were beginning to emerge. And news companies were creating league tables, highlighting places with the best and worst vaccination uptake rates. But this missed important context about people and place. In the top 30 most highly vaxxed suburbs, held up as leading the way, places like central Auckland, Wellington and Queenstown, the furthest you had to drive to a vaccination centre was just 5 minutes. You could hardly walk down the street without getting a needle in your arm. On the other hand, in towns like Murupara, held up as the slowest in the country, derided as holding us all back, the median age was just 29. Most people had only just become eligible for the vaccine at all. And the closest permanent clinic was almost an hour's drive away, one way. You had to have the time, resources, and make a huge effort to get vaccinated in a place that was basically a vaccine desert. Our analysis showed that across the whole country, regions where access to services were better had higher, more equitable uptake rates. So what did we learn in this particular crisis? Well, we can actually come together and work on really difficult issues. We can reprioritize, shift our focus, and work quickly with limited resources to meet new, unexpected challenges. But if we don't focus on designing fair systems that will work for everyone, inequities are inevitable. And I think that's unacceptable. We also learnt that access is important. People have to be able to get to the services that they need. And we need to do more to create fair, robust systems that are ready for future challenges. So, what are these future challenges? The world's changing, and that includes the population tide. Is anyone here over 65? Oh, someone's got your gold card? Yeah, good. I thought there'd be a few more of you, because in the next 4 years, Stats NZ projects that there'll be over 1 million people in this age bracket, and that will continue to stretch our health resources. By 2050, a quarter of us will be over 65. The number of people 85 or over will have doubled to over 200,000. At the same time, in Aotearoa right now, there are almost 1 million Māori, and this is a really youthful population that's growing. The median age is just 27. So how do we balance these two different demographic changes? How do we look after our older people and meet obligations to our younger people, both now and into the future? How do we ensure that they have the conditions where they can flourish, dream, and realize their aspirations? And how do we avoid embedding the unfair and unacceptable inequities that exist today? We'll have to do things differently, lift living conditions for everyone, and create a fairer society. And part of that will be delivering services differently. So we'll urgently need to train more doctors, nurses, physiotherapists, and pharmacists from diverse backgrounds who are willing to work in places that have too often been left off the health map. And at the same time, our environments are changing. Climate change is an existential crisis, and it brings new challenges like extreme heat and extreme weather events that are becoming stronger and more frequent. Cyclone Gabrielle caused $14 billion in damage to property and devastating loss of life. And in the aftermath, damage to infrastructure like roads and telecommunications meant that people couldn't easily get the healthcare help that they needed. These are challenging, intersecting and interconnected issues. Wairoa lost their only aged care facility in the aftermath of Cyclone Gabrielle. Nobody's got a single simple solution, but research can play an important role. If we work together to understand these challenges and their nuanced detail, we can start to create solutions that work. And we're starting by collaborating across the university and the country, but also with researchers in Australia to develop new cutting-edge geospatial techniques to quickly assess access to services before and after disasters. And we're building relationships with research teams in Japan, where they have many of the same, if not more extreme, challenges, to start understanding how we could build equitable and resilient health systems ready for these future challenges. Dad? Oh, that's right. Monday morning, time for me to think about my own death. Darling, it's pretty complicated. Nobody knows when they'll die. But if we work together to create a fairer society, we can all live longer, healthier lives.